A very good morning to all. So today's topic is the newer therapies of MASLT. So initially, just a brief overview that what is the prevalence and incidence. The global NAFLD prevalence is around 38%, with around 5 to 7% of lean MAFLD in the general population. Prevalence of lean NAFLD is around 20 to 40% within the NAFLD population. F1, F2 prevalence of 7 to 8%, F3, F4 of around 1 to 2%. In patients who are severely obese, the prevalence of NAFLD is nearly 90%. So the current, with the change of definition, MASLD is anything which has steatotic liver disease with and to assess whether the patient have any cardiometabolic risk factors, and based on the alcohol intake, we stratify them on MASLD, and if the alcohol intake is high, then either MET ALD or ALD. So this is the brief overview. I'll be presenting this topic on two parts. The first is the newer therapies, and from the therapies we'll see how things have moved forward as far as the secondary endpoints are concerned. So after 2021, there are multiple drugs which are currently either completed phase 2 or phase 3, semaglutide, lanifibranor, the FGF inhibitors, the fatty acid inhibitors, the denifanstat, or the GLPs along with that thyroid binding receptors. So the FDA efficacy endpoint for phase 3 trials is both MASH resolution, that is resolution of steatohepatitis on overall histopathological readings with no worsening of fibrosis, and fibrosis improvement of more than one fibrosis stage with no worsening of steatohepatitis. This is the primary objective, but there are various secondary objectives which in different trials they have used, and this is probably what we'll study in the second part. The first of the drug which is FDA approved is the resmetirom, which is a THR beta agonist, which is predominantly expressed in liver, and its activation enhances the mitochondrial beta oxidation, reduces the de novo lipogenesis, and promotes hepatic cholesterol clearance. This is the MASTRO-NASH trial, which is a phase 3 RCT of 966 patients, biopsy proven F1, F2, F3. The mean BMI was 36. Resmetirom given in dose of 80 or 100 along with placebo. The primary endpoint was assessed at 52 weeks. MASH resolution compared to placebo was seen in around 29% in the 100 mg group and 25% in the 80 mg. Similarly, the fibrosis improvement was also significantly better in the treatment arm. The other secondary objectives were all significantly decreased compared to placebo, and there was a decrease of the FT4 and increase of the active FT3. But the overall effect has, there is no central effect, and there is no pituitary hypothalamic suppression because of this change in the thyroid profile. So the recent clinical practice guideline, they indicate resmetirom when there is an F2, F3 fibrosis, LSM of more than equal to 8 or less than 10, LSM more than 10 or less than 16 in the absence of cirrhosis, 16 to 20 if a second NIT rules out cirrhosis, and not to be prescribed in patients with cirrhosis and signs of portal hypertension. The second group of medication are the GLP or the incretins, which primarily works on the GI tract with increasing the gastric relaxation, decreasing gastric emptying. They also act on the central nervous system by decreasing appetite, and in the pancreas by increasing the insulin secretion. GLP along with GIP or glucagon will also have effect on the energy metabolism, and they will also increase the uptake of free fatty acids. The first of the medication is semaglutide, which recently has been second FDA approved drug for the treatment of MASH. They have updated last week only. This was the ESSENCE trial. Ongoing phase 3 RCT of 1197 patient, biopsy proven F2, F3, BMI of around 34. Semaglutide 2.4 mg subcutaneous once weekly with placebo. The primary endpoint assessed at 72 weeks, and the interim analysis of 800 patients were there, which they have published. So in the MASH resolution was seen in around 62% of the patient compared to placebo 34%, and fibrosis improvement in 36% compared to 24% in the placebo. They have mentioned that the overall less improvement of MASH resolution or fibrosis, that could be because of the genetic polymorphism, which as a determinant of therapeutic response. We'll study about the genetic polymorphism in the second part. Then the other secondary endpoints which are also important in the clinical aspect is the decrease in the ELF score, and a DLF score of 0.5 or more, which was the predefined decrease of ELF, was seen in 55% in the semaglutide arm compared to 25% in the placebo. Similarly, the liver stiffness also achieved more than 30% in the treatment arm compared to placebo. The mean weight reduction was around 10.5%. So the indication for starting semaglutide in the recent practice guideline is MASH with stage 2, stage 3 fibrosis identified using an NIT or VCT of 8 to 15, MRE of 3.5 to 4.4, and ELF of 9.2 to 10.5. If it is the NITs doesn't rule out cirrhosis, then more confirmatory tests are needed. The second of the incretin is the survodutide, which is a dual agonist, glucagon receptor plus GLP-1 receptor agonist, which have completed the phase 2. This was also biopsy proven, BMI 35. Survodutide was given once weekly dose of 2.4, 4.8 and 6 mg, and the primary endpoint was 48 weeks. The dose escalated till first 24 weeks, and the response was assessed at 48 weeks. In the treatment arm, of 4.8 had a significantly improved outcome compared to placebo, and the stage of fibrosis, which was one of the secondary endpoint, also improved in the treatment arm. The third is the tirzepatide for the metabolic for MASH with liver fibrosis, which is also a dual agonist of GIP and GLP-1 receptor agonist. This is the Synergy NASH trial, phase 2 RCT, tirzepatide of 5, 10 or 15 mg with placebo, primary endpoint assessed at 52 weeks. The treatment arm had shown improvement as compared to placebo, both in the MASH resolution and fibrosis improvement, and currently the phase 3 trial is ongoing. Then another group of drug is the fatty acid synthase inhibitor, which decreases the de novo lipogenesis and improves the mitochondrial function, is the Fascinate-2 trial, which is a denifastat given once per oral, once a day, 50 mg, and 52 weeks was the primary endpoint, and the NASH improvement of more than 2 points without worsening of fibrosis was better in 38% compared to placebo, and resolution of NASH without worsening of fibrosis was also seen in better in the treatment arm. The ongoing phase 3 study is the Fascinate-3. Important secondary endpoints that they have mentioned is the change in the quantitative, architectural and the morphological distribution of the collagen, which they have assessed based on the Q fibrosis score, which is a AI assisted digital pathology. So what is the absolute change is 0.3 in the denifastat compared to placebo, and the percentage change is 6%, or in compared to placebo there is 10% percentage change in the Q fibrosis score. We'll discuss this in detail in the second part. Also, in the lipidomic, the serum triglyceride had increased, but in the lipidomic analysis, what they found that the higher content of polyunsaturated fatty acid had increased compared to the saturated fatty acids. Then the pan-PPAR agonist lanifibranor in NASH, another phase 2b, which is complete, and the treatment arm effect as far as the NASH resolution was better compared to placebo, and the ongoing phase 3 trial is expected to be completed by around 2026. Then another important target is the FGF, or the fibroblast growth factor 21 signaling, which this FGF21 has all the paracrine, autocrine as well as the endocrine effect. It acts in the adipose tissue by increasing the insulin sensitivity, glucose uptake, as well as adiponectin secretion. It decreases the sweet and the alcohol preferences in brain. In the pancreas, it increases the beta cell function. Muscle increases insulin sensitivity, and in the liver, it increases the fatty acid oxidation, as well as decreases the de novo lipogenesis. The first of the FGF analog, the main problem of FGF is that their half-life is very less, but the analog, that is the glycopegylated component, it increases the half-life as well as the efficacy by nearly 100 to 300 times. This is the phase 2b, which is completed, the Endlevin study, biopsy-proven MAFLD of BMI 36. And the fibrosis and MASH resolution were better in the treatment arm compared to the placebo. The second was the efruxifermin, which is the Harmony trial, where they have also used another non-invasive test, that is the NIS4, to rule in NASH, and they found that the primary endpoint of 24-week, which was the fibrosis improvement, was better in the treatment arm compared to the placebo. This trial was done in 2 phases. One was at 24 weeks and one was at 96 weeks. And even the 96 weeks is completed, where they have found that the fibrosis improvement of nearly 75% or a 52% difference compared to placebo could be achieved in the treatment arm. The other phase 1 studies are which have completed and which are positive, and they have continued the phase 2 study. One is the pemvidutide, which is a GLP-1 and glucagon receptor dual agonist, phase 1 MASLD, BMI more than 28 with liver fat content of more than 10%. 3 treatment groups were there, 1.2, 1.8 and 2.4 mg compared to placebo, once weekly dose. 12 weeks was the assessment time, and the objective was to consider the efficacy of liver fat content reduction, which was significantly better in all doses with a maximum weight reduction of around 4.3%. Then survodutide, this was GLP-1 glucagon, but this is for the cirrhosis MASLD patient. The CTP A, B and C, all the 3 cirrhosis groups were included, assessed at 24 weeks, and the main objective was to assess the drug-related treatment adverse events. And survodutide is generally tolerable, and it is now currently into phase 2. All these medications, they have one particular mechanism of action, and NASH might be having more than one action. So there were many combination treatments were assessed previously based on the tropifexor or the Sensiviroc. But currently there are 2 which I would like to discuss. One is the semaglutide plus cilofexor plus fircostat, completed phase 2 study, where the primary objective at 24 weeks was to assess the safety. Weight loss was not very different in the combination arm compared to semaglutide, but the fat loss was better in the semaglutide plus fircostat as well as that 3 drug combination compared to the monotherapy alone. Then recently published another combination. This is an investigational drug, TERN-501. This is a thyroid hormone receptor beta agonist, along with TERN-101, which is an FXR agonist, and they found that the significant reduction from baseline in MRI-PDFF compared to placebo. So these going ahead is the role of the bariatric surgery. The surgical, when we discuss treatment for a severely obese patient who have an underlying NASH, considered for bariatric surgery, in this Splendor cohort, where patients who underwent bariatric surgery compared to those patients who were non-considered for surgical and were taken as control, over a period of 10 years, both the weight reduction and HbA1c control was much better in the bariatric surgery group. And they also found that at 10 years, the major adverse liver events were significantly less in the bariatric surgery group as well as the non-surgical. And those patients who had NASH with obesity at baseline, they had higher incidence of these major adverse events. This was further studied in the French cohort, where the bariatric surgery patients of 180 biopsy confirmed NASH patients, they were prospectively followed, and at 5 years it was found that nearly 84% had NASH resolution with no worsening of fibrosis. NASH resolution were better in those patients who could achieve more than 10 kilogram per meter square of BMI loss. Overall 48, the mean BMI was 48 and the mean loss was around 12. Compared to those who could not achieve a weight loss, nearly 40% still had NASH at 5 years. And when they assessed the fibrosis till 5 years, it was found that the reduction in fibrosis, it continued till 5 years. In fact, those patients who had baseline F1 or F2 fibrosis, nearly 70% of those patients by 5 years had complete loss of fibrosis. So these drug treatment give us a few important questions to ask. One, why always there is a placebo effect? Do we treat all the obese patients? Whether there are better biomarkers for identification and treatment response? How AI-guided image digitization, especially the Q-fibrosis, have been used in the recent clinical trials, and why there is talk about genetic polymorphism. So the rates and factors which are associated with placebo response in this meta-analysis of 39 RCTs of 1,463 patients, patients were assessed based on liver biopsy, MRE or MRI PDFF. It was seen that nearly 2-point decrease of NAS in the placebo arm could be achieved up to 25% or 21 to 29% with mild heterogeneity in all the studies. Also, there was 1-point improvement in steatosis, ballooning, lobular inflammation, and fibrosis in nearly 1/4 to 1/3 of these patients. So, on meta-regression multivariate analysis, it was found that those patients who had a higher baseline NAS, patient had a decrease in BMI, they had relatively better placebo effect as compared to the others. And the secondary endpoints were reduction in the IHTG, the intrahepatic triglycerides, reduction in AST and ALT were these. Then looking into the biomarkers, one of the important biomarker is ProC3, which is being studied majorly in all the clinical trials. And there is a ADAPT, which is an algorithm which incorporates the ProC3. ProC3 is the procollagen C3. In this study of 431 NAFLD patients, where the derivation was done in 150 and validation in 281 patients, the primary objective was to see the association of ProC3 with liver fibrosis, and it was found that patients with F3 or above, they had significantly higher ProC3 compared to those who had F2 or lower compared to F0 or F1. Also, when they incorporated the clinical and other parameters and they made the ADAPT algorithm, which is age, presence of diabetes, platelet count and ProC3, they found that the identification of advanced fibrosis with ADAPT is nearly AUROC of 0.86, and this had fared better compared to the more conventional markers like FIB4, NAFLD fibrosis score or the APRI. Then another important question is that whether all patients of obesity, do we need to treat them in the context of MASH or MASH? In this study of the discovery cohort of 160 bariatric surgery patient, BMI of nearly 45, after surgery, the incidence in a bariatric surgery patient was seen in, the mast cell was seen in 53% and MASH was seen in 20%. So what they did that they initially tested the plasma, the liver secreted proteins. It was around 3,300 odd liver secreted proteins, out of which around 102 were the plasma proteins which were more related to liver. And after that, they used the liver biopsy, the thin splice liver tissues were taken and the protein extraction, and then they were assessed on the mass spec. So this was around 36 liver related proteins were there which were more related to MASH. The upregulated are the majorly the metabolic pathways that they affect, that is the regulation of coagulation, complement activation and inflammatory response. And based on this, they made a APASHA model, which is the apolipoprotein F, the protein convertase substituent or the PSK9, FMN, S100, HbA1c and AZP1, and they found that the APASHA was better to predict MASH in validation as well as the derivation as well as the validation cohort. Then we need to assess the AI guided images. This is the Q fibrosis which was assessed in the fatty acid, the denifanstat study. What is exactly Q fibrosis? It is an automated technique for quantitative assessment of fibrosis, inflammation and steatosis, and it uses the second harmonic generation or 2-photon excitation. So what exactly is a 2-photon? This is the conventional fluoroscopy where a single photon is beamed. It causes a vibration as well as relaxation in the tissue, and then it is emitted back, which is then read by a camera or the software. In 2-photon, the 2 photons, they are emitted at a very narrow time gap of around 50 femtoseconds. In that way, they could achieve a higher wavelength. The 2-photon excitation will also have the similar pathway, that is vibration followed by relaxation, and it would be assessed by the software. By increasing the wavelength, since wavelength is inversely proportional to energy, it will cause less chance of photobleaching, And also, since wavelength is less inversely proportional to scattering, so this has been used in the deep tissue penetration. This 2-photon microscopy or fluoroscopy has been vastly studied in the functional studies of the neuronal activation, and this has been studied even in the current study. So again, coming back, the 219 patients who had liver biopsy, they were quantified based on the fibrosis, inflammation, ballooning, and steatosis, out of which these many parameters were finally assessed, and a model was created, which was the Q fibrosis, and they used the whole slide imaging. And it was found that for each of the parameter, that is Q fibrosis, inflammation, ballooning, and steatosis, it has very good correlation with the conventional fibrosis and NAS aspect, and they could make it a continuous variable with Q fibrosis of 0 to 6.5, inflammation of 0.6 to 3.3, ballooning from 0.2 to 1.96, and steatosis from 0.8 to 2.1. AI-guided image digitization was studied in one of the study where the Aramcol of 300 mg was given with placebo. The aim was to compare the single fiber digital image analysis compared to the conventional pathology. There they used the platform PharmaNest and the phenotype fibrosis, the composite, because this also makes it a continuous variable. And what they found that the outcome of fibrosis improvement based on the NASH CRN was achieved by only 31%, but based on this PharmaNest continuous digital platform, nearly 74% have achieved a fibrosis improvement. Last part is the genetic polymorphism. So what exactly is genetic polymorphism? This is the GWAS or the genome-wide association in the different ancestry. The gold is the genetic of the obesity-related liver disease. This is CT-guided fat estimation, and gold plus is those which have also incorporated the UK Biobank as well as the Finnish registry. EAF is the estimated allele frequency of a particular gene with the pathological or the variant RNA. So the European ancestry, the PNPLA3 RS738408, which is the most common, seen in up to 23% of these patients. Similarly, other gene variations of TM6, SF2, ApoE, GCKR, TRIB1, and ADH. In this study, they, along with the GWAS, they also switched over to the PHIVAS. So what is PHIVAS? PHIVAS is phenotype-wide association, and they found that the PHIVAS usually could be substratified based on a low lipid output, a high normal lipid input, low lipid burnout, the insulin resistance, the problem in absorption as well as diversion. So when they studied the different SNPs, it was the main point is that any SNP will not cause only a single problem. It will cause a varied problem. That is why they wanted to study the effect of the phenotype along with the PNPLA3. So the more the red, more is the effect. And this arrow, if we follow, this is the development of fibrosis, and third is the PNPLA3. So it is more towards pink or red, so it has effect. But when we see, it also has effect in ALD, it also has effect in other metabolic parameters. This genetic association was studied, the 5 major genetic association that were studied is the PNPLA3, the minor allele frequency of around 26%, and the odds of developing a NAFLD, NASH or HCC were significantly higher. In the TM6SF2, the minor allele frequency in the population is up to around 7%, which may be around up to 16%, which has higher odds of developing MASLD or MASH. GCKR around 29%, MBOT 37%, and HSD7, which is the protective one, which is seen in around 18% frequency, this particular SNP, with 16% lesser chance of developing MASLD, NASH or HCC. So this particular genetic polymorphism is important even in simple interventions like weight loss. So patients who were NAFLD, when they were assessed for intervention of 12-month intervention compared to control, those patients who had PNPLA3 mutation from I148 to M, they had increased fat reduction. This was seen also in patients who had underwent bariatric surgery, where they found that increased reduction of liver fat or reduction in BMI and triglyceride were also higher in the PNPLA3 group. So this PNPLA3 currently has been studied in a phase 1 trial, or the proof of concept, where the siRNA PNPLA3 were given in two cohorts. One is the Japanese cohort and other cohort. And the patients were placebo, heterozygous for PNPLA3, or homozygous at different doses. And it was found that the significant reduction in fat content in liver were significantly higher in only those patients who were homozygous for PNPLA3 and they had received a higher dose compared to the heterozygous one. So this is basically a proof of concept study, but this is probably one of the reasons that things are moving more towards a precision medicine. So to summary, there are multiple potent drugs which are currently available. FGF21 is definitely promising. Many GLPs are still on pipeline with a combination treatment, but cirrhosis trials are still need to be explored. The AI-guided image digitization is a very important tool, and genetic polymorphism is important because probably the genes are making the overall environment more obesogenic, and it will definitely guide us whether all obese patients need treatment or not. And with this, there could be more room for endobariatric options. So finally, how things are moving towards personalized medicine is by not just by the evidence that we have, but it is more related to genomics and omics and radiomics. Thank you.